why is this topic so important? With the changing era, there has been an exponential increase in number of patients undergoing TKR globally, with more than 1 lakh patients undergoing TKR annually in India alone. Also, as we all know, there's a gradual shift of TKRs from being performed conventionally to handheld computer navigated or robot arm TKR for flawlessly achieving the goals of better alignment, precise implant positioning, reducing the wear rates, for improved patient satisfaction and superior clinical outcomes. However, this is a surgeon's perspective. Be it conventional or robotic, all that the patient wants is a pain-free mobile knee and an early return of function and ambulation, neither of which can be achieved without adequate pain control. Hence, pain management in TKR has remained a prime topic of discussion and seen substantial development over the last few decades. In an editorial published by Dr. Javed Parvizi in JBJ's 2012, he effectively pointed out that we fail to control pain well in approximately 50% of the patients undergoing joint replacement surgery. He highlighted the use of newer modalities of treatment like preconditioning, multimodal analgesia, liposomes, and transdermal patches, abandoning the use of epidurals, patient control analgesia, and sciatic nerve blocks in favor of intra-articular injection. So, what are the issues arising due to inadequate pain control? The persistent pain and discomfort leads to anxiety, reluctance to initiate physical therapy, leading to delayed mobilization, slowed and poor rehabilitation, increased opioid or post-op consumption of pain meds, with its own list of side effects like nausea, vomiting, and sedation, etc. All of this leading to increased length of hospital stay, apart from the burden of higher cost of care. This poor perioperative pain management leads to compromised ultimate function, patient dissatisfaction, which negatively influences the choice of physician and patient's willingness to undergo further treatment. As we all know, we have always done pain management after the surgery. The patient would undergo surgery, would wake up in pain post-operatively, after which the pain management would be initiated. However, the patient would suffer miserably with pain till the effect of medications would kick in. Over the years, there has been a paradigm shift in the approach of pain management in TKR, where the clinical concept of preemptive analgesia came in effect. It involved initiating the pain management process prior to surgery, that is, before the noxious stimuli sets in, using a multimodal approach by giving different types of nerve blocks in addition to periarticular infiltration. So, the aim of preemptive analgesia is to deliver clinical and cost-effective pain relief before the noxious stimuli due to surgery sets in, that is, pre and intraoperatively. So, this is the flowchart depicting the various modalities of treatment options available in the pre, intra, and the post-op period. So, let us see what is best that can be done in the pre-operative period. Numerous studies have shown better post-op pain control and reduced anxiety in the patients who received specific information prior to surgery. Also, clinically, they were more satisfied with the post-op pain management. Therefore, there has been a strong consensus in advocating the use of patient education and counseling. The education can be aided by explaining on knee models, using information pamphlets or brochures, and or providing educational videos for better understanding in what is to be expected in the perioperative period. Preoperative strength training has also been emphasized in prehabilitation. All of these effectively reduce the pre-op anxiety. And of course, the use of medications can be less stressed upon. In today's date, where we have tried shifting to opioid-free analgesia, owing to its numerous side effects, we have many other better medicines which are good in taking care of the pain on a temporary basis. For examples, NSAIDs and COX-2 inhibitors have been successfully used to control arthritis pain, with superior impact if given both pre and post-operatively, rather than just post-operatively. There is evidence that paracetamol in the IV form works better than the oral paracetamol, but the impact is nonetheless modest. Various centers abroad still continue using long-acting oral opioids like oxycodone preemptively. Transdermal patches like buprenorphine and fentanyl patches can be used before undergoing surgery with caution. Again, these class of narcotic drugs should be reserved for managing patients having unbearable pain only after exhausting the non-steroidal medications available off the shelf. Initially, where gabapentinoid showed promising results when used preoperatively, multiple studies have shown that there is no conclusive evidence that they should be used as such. Let us see what is it that can be done best intraoperatively, apart from the standard neuroaxial and general anesthesia. So the main focus for intraoperative pain management is periarticular multimodal injection, so-called cocktails. It is a common practice to use them, but the components of each of these cocktails vary. Combination is that of a local anesthetic like bupivacaine, ropivacaine, or opivacaine, ketorolac, and adrenaline. Some people may add antibiotic, some may add clonidine, some may add dexmedetomidine, some may add steroid, and dilute the whole solution to 120 ml. The use of steroid in these cocktails is controversial, especially in diabetics, as it may hamper the wound healing in a few. Better avoid adding morphine. The use of liposomal bupivacaine demonstrated modest improvement in pain and pain scores and activity, and diminished post-op narcotic use compared with simple bupivacaine. However, the cost is higher. The most important thing about periarticular multimodal injection is the technique and timing of injection, which we will shortly see. The other modalities that can be used intraoperatively are systemic steroids like dexamethasone, which seem to work due to its anti-inflammatory action, reducing the pain and giving a generalized feeling of well-being. However, it is supposed to be used with caution in diabetics. Some people have tried intra-articular pain control infusion pumps. However, there is no strong evidence that it works, and then there's the added risk of infection. Intrathecal opioids have also shown their efficiency in pain relief, but you should be aware of the risk of pruritus, respiratory depression, nausea and vomiting, etc. The use of tourniquet is a controversial topic and also less spoken about with respect to pain control. There is a recent Cochrane review which showed significant, that is more than 10% reduction in pain in the group undergoing surgery without tourniquet. Also, the risk of serious adverse events reported was probably higher with tourniquet than the ones without tourniquet. So the use of tourniquet can be minimized. The only potential benefit of tourniquet use is during cementation. This is also currently associated with a very low certainty of evidence, as there are surgeons who successfully do TKR without tourniquet. Coming finally to describing the technique of periarticular infiltration, it is used as a measure of regional analgesia to block the transmission of pain. For the same, it is important for us to know the nerve supply around the knee. The knee is supplied by 4 different important nerves in the lower limb. The primary supply around the anteromedial aspect is through the saphenous nerve, a branch of femoral nerve. Then the tibial and common peroneal nerve supply the posterior and lateral aspect. There is contribution from the obturator nerve also. This is done through contribution of various plexuses, namely the peripatellar, subsartorial, and popliteal plexuses. This is a classical paper which describes the periarticular knee injection given in 8 different zones. The technique proper, an 18-gauge needle is used to give multiple injections, taking good time while injecting in each area, and the timing is important. 2 injections are given prior to cementation and implantation. The first one is in the posterior capsule of the femur and PCL. The injection is given in the notch after aspiration. You can see the distension of the capsule followed by PCL and then around the femoral attachment of the ACL. The second injection is also given before implantation and is in the posterior medial aspect of the tibia. Always aspirate and inject in each of these areas. After the implantation, the medial capsule is injected with the fluid. You can very beautifully appreciate the distension of the capsule with the infiltration. This is followed by injection in the area we have worked maximum in a varus knee, which is along the area where we have done medial release. And you can see how the area is being infiltrated. Once the medial side is taken care of, we infiltrate the lateral gutter. Once again, we can beautifully see the capsule distending. One must know that the capsule is one of the most pain-sensitive part of the knee joint. It is followed by parapatellar arthrotomy infiltration, and you can clearly see how the fluid is infiltrated along the edges of the medial parapatellar incision. This is followed by infiltrating the infrapatellar fat pad, again an area which is densely vascular and rich in nerve supply. Whatever is remaining is now injected in the subcutaneous plane. For this, typically 120 ml solution of used, and all the syringes are of 20 ml. The first 2 syringes, those given posteriorly, are of 10 ml. The idea is not to inject too much in one region, especially if adrenaline is used, and to distribute it all over. This concludes the periarticular injection. Now, one of the gold standard in managing peri and post-op pain is the ultrasound-guided adductor canal block. And very quickly about the anatomy. You can clearly see the femoral artery, the femoral vein, along with the saphenous nerve in the adductor canal. The nerve to vastus medialis, which lies in a separate canal immediately outside and lateral to the adductor canal. You can now see how the injection is being given. You can see the needle entering into this space. You can see the femoral artery which is pulsating on the left side. How the infiltration is opening up the first canal sheath carrying the nerve to vastus medialis, followed by the micro advancing the needle till a giveaway is felt, confirming the entry into the adductor canal, after which the infiltration is injected after aspiration. We have described a unique technique of surgeon administered direct adductor canal block. And one of the reasons why we did that was because we felt that while we were operating in close proximity with the adductor canal region, it is very easily accessible via a spinal needle from the operative site. Here you can see the target region, that is in the adductor canal, is really close from the superior flange of the femoral process. This is the typical entry point for the direct adductor canal block, and a short video here will show how we administer it. So we use a spinal needle to deliver the direct adductor canal block, or the DACB, with an entry point approximately 2 finger breadth above the superior flange from the anteromedial border of the femoral shaft. The needle is directed around 10 to 15 degree medially and 15 to 20 degree posterior superiorly. The entire needle goes in, we aspirate it and inject it gradually while withdrawing the needle. Aspiration is important to know we are not intravascular, and this injection withdrawal technique helps ensure there is a diffuse spread of the infiltration in the entire adductor canal. Those of you who are interested can read the technique in the research article we have recently published in knee surgery and related research, which gives control to the surgeon for giving adductor canal block with periarticular regional analgesia. Going over to the postoperative pain management, femoral nerve block were popular, but the delay in mobilization due to weakness in quadriceps has been directly related to the incidence of falls and occasionally periprosthetic fractures because of them. Sciatic nerve block are obsolete as apart from delay in mobilization, they have known to mask foot drop, cause heel ulcers because they develop a dead leg and can't feel pain or move the leg. Also, it causes rebound or breakthrough pain as the block wears off. The key home message from this slide is to use adductor canal block, either anesthetist given USG guided adductor canal block or surgeon administered DACB, which does not require ultrasound machine nor an ultrasound trained anesthetist. These blocks are superior because they are primarily sensory and they do not give any motor blockade, unlike the femoral and the sciatic nerve blocks. Few other described post-op modalities are the IPAC block, which is given in the interspace between the popliteal artery and the posterior capsule. Some people have started giving this in addition to the ultrasound-guided adductor canal block because the ACB will primarily give you pain relief only over the anterior and medial aspect. We all now know patient-controlled analgesia has gone out of favor. Modalities like peripheral nerve stimulation has been tried, although it is in the initial stage of evolution. IV ketamine and dexmedetomidine can be used during spinal analgesia. Cryotherapy can be used to administer cold compression using gel packs attachable on the pressure controllable inflatable knee racks. Finally, I would like to conclude by saying pre-op education and rehabilitation does make a difference by reducing anxiety and expediting recovery to an extent. Multimodal pain management is the key. High volume periarticular infiltration at different zone provides good short-term analgesia. It must to be supplemented with nerve block, either ultrasound guided ACB or surgeon administered direct ACB. At the same time, there is no consensus on the content of the block. In general, it should be a combination of short and long acting pain modulator and adjuvants. All of this is to take care of the pain in the first 24 to 48 hours, which is the key. NSAIDs and COX2 inhibitors can be used pre and post operatively. and possibly IV paracetamol also can be used. Better preemptive analgesia rather than reactive analgesia. No need to use pre-op gabapentinoids. Prefer not to use local steroids. You may choose giving systemic steroids by selecting your patients diligently. Try and limit the use of tourniquet. To conclude, early or same-day mobilization helps. I thank you for your patient listening.